My name is Beissbarth. I'm working at the Department of Medical Statistics in Göttingen, at the University Medical Center in Göttingen, and my area is kind of statistical bioinformatics. And the title is how to use molecular networks to predict the individual treatment outcome in cancer patients. So this probably leads a little bit more to the virtual patient than the virtual cell. But yeah, my area is more like statistical prediction. So the general idea in personalized medicine is I'm working at a university in the hospital, and we're working on a lot of projects where we are working very close to medical doctors, and we're also involved in kind of evaluating clinical trials. And usually the way that this works at the moment is that you have one therapy and you have another therapy, and you evaluate like on the whole population of patients which of the therapy works better. Not you have some kind of clinical trials for that, and you assume with this somehow that all the patients kind of would react the same way, better to the one or the other therapy. But especially for cancer, it is the case the patients have they have different genetic backgrounds, cancer has a different history, there might be different subtypes of tumor really, so cancer is not really one disease, but it might be really a whole lot of different diseases. And also that patients respond with different levels of toxicity to different therapies, not especially for cancer treatment. The toxicity of the therapy is a very important aspect. Of course, you can shut down the cell, but you might shut down the life at the same time. So the idea is that with individualized therapy, so if we now could predict, for example, which patient would respond better to one therapy than another, you wouldn't need to compare the therapies in itself, but you would stratify the patients to different criteria, maybe molecular profiles or something, and treat each patient according to his best therapy. So that's pretty much a picture of the idea. So usually the patient comes into the clinic at some point with some form of cancer, for example. At the moment, we have a lot of techniques to measure a kind of high throughput genomics, like either SNPs or gene expression signatures for microarrays, or other kind of molecular markers you may use. Then often the patient gets a therapy, and either the patient responds, for example, you could measure this by the tumor which got smaller during the therapy, or by kind of time the patient survived, and classify these into responders or non-responders. And the hope is that we can predict from these molecular markers at the beginning the outcome of this therapy at the end. We're working especially on this topic in Göttingen in a clinical research group which is working on rectal cancer. And one way I think that Alexander also presented in his last talks is, of course, to try to understand the cellular pathways and the cellular mechanisms which work and how they work, and predict the outcome of these networks. I try to sketch this because especially for breast cancer, kind of this individualized treatment is probably furthest developed, and this is actually the same pathway that Alexander also showed in his slide. It's the EGF receptor pathway, so we learned already there, if you put in a lot of EGF on the cell, then usually the cell moves. So EGF is the growth factor, so should kind of control whether the cell proliferates or doesn't proliferate. So if you put a lot of EGF on it, or there's actually a lot of other ways to break this pathway somehow, then usually the patients get cancer, and their pathway shift in a way that the cellular state goes into the state proliferation, or even worse than proliferation, migration. So the cell migrates somewhere and, for example, forms a metastasis in the liver or something. And we want them actually to go into the state apoptosis rather. And there's a lot of drugs in the meanwhile which kind of try to regulate these pathways at different levels. Here there's just 3 of the drugs by Roche mentioned here. And of course, by understanding this pathway further, we hope that we can interfere at certain types better, or we can also predict the outcome of the patients better. An approach that my group does a lot is to try to reconstruct pathways from data. I actually just want to mention this quite shortly today because I'm actually giving a talk on Wednesday where I speak about in the session on network reconstruction about different methods of reconstructing cellular networks, or basically, we are often here, or today we talked a lot about the databases and the collections under the assumptions, of course, that the networks are, or at least a lot of it is known already. And especially for cancer cells, where I believe the networks are quite different than the networks which they are occurring in a regular cell, I think there's a lot of the networks which aren't known. So our kind of approach is that we usually use some measurements on the protein states and protein phosphorylations. We get time series data, and then we use methods to reconstruct the signaling networks within the cell. Here is just an example of the workflow, how we use RPPA data, which is reverse phase protein data, and we've developed a method called deterministic effects propagation networks. For this, as I said, I'll talk about this on Wednesday, so I won't go into detail today. Just briefly, it's a type of a Bayesian network, pretty much. Another approach just that I want to mention from the idea, a very important concept with understanding pathways is introducing, especially in cellular systems, certain types of perturbation. This is another kind of pathway where, for example, here, which actually comes from bacteria, the LPS receptor leads to different responses, the REL pathway as well as the JUNK pathway, which leads to the activation of antimicrobial genes or pro-apoptotic genes. And actually this was a kind of signaling cascade was found by shutting out certain types, one molecule at a time, and then seeing, okay, if I knock down TAC, then I see, okay, here all those genes go down. And if I knock down REL, just this part of the pathway goes down. And if I knock down this, just this pathway goes down. So by this kind of nesting of the structure of the effects, you can kind of get an idea about the signaling cascades which happen above. And actually we use mathematical formalization to reconstruct pathways based on perturbation experiments, which is called the nested effects models, which I'm also shortly going to introduce on Wednesday. So today I want to speak a little bit more on how, as the title suggests, how could we use now this network knowledge in actually the thing clinical prediction, which I talked about before, because all of the things, these reconstruction approaches, they try to understand biology. They're not, which is important and probably our ultimate goal, but for the clinical problem that we're facing, usually people use much different approaches at the moment. These approaches usually come from the area of machine learning, so you just because the aim there is just to predict. You don't care whether the functions that you use to predict or it doesn't function, but you train you train a classification model based on labeled data of patients and try to predict outcome. And the measure how good you predict outcome is actually your measure how good your method works. A problem from the machine learning perspective in this is actually that we have, for where you have a few genes and many patients, there's methods which do this very well. But here we are very limited in the number of patients. So we usually, if we get cancer patients and we get microarrays, we are really lucky if we get somehow in the several hundreds, not so we can't get kind of in the several thousands. And we measure more and more features. We measure many thousand genes. And this is from the point of statistics, just a geometrical problem. As soon as you have more genes or more features that you measure, then you have observations which you use to build a classifier. You will always find some way to distinguish the patients. If I wanted to distinguish the people here in the room according to maybe whether they're mathematicians or computer scientists, I would probably find a lot of features which had nothing to do with it just by chance, not just by looking at a lot of different features. And this is called the so-called curse of dimensionality. And it's hard to avoid this kind of theoretically. But this leads us back again to this understanding of pathways. How does understanding of pathways now help us maybe with this classification problem? And we developed an approach in my group that we said, okay, if we use these molecular networks that we know maybe from other knowledge, as a background information in this classification algorithm, for example, focus on certain like the hubs in these networks or genes we consider important as classifiers, then we might actually get a better classification performance than if we just train a classification algorithm without the knowledge of these networks. And we actually combined two kind of common methods or ideas here in a workflow. Our workflow here is that we use gene expression data, and common in this kind of machine learning setting is that you split your data into a training and into a test set, because otherwise you're really prone to overfit your data. In your training set, you kind of learn your classifier, and you might even do this repeatedly in a cross-validation to kind of see whether you always end up with the same classifier. In the training set, you train a classifier. Here we use a well-known method called the support vector machine. And in the test set, you just validate, okay, how good do you predict now new patients which you haven't seen before. And here we use additional information. We use information from protein-protein interaction databases, networks. We use an algorithm called GeneRank on these to kind of score the features, and we combine this with the classification information and see whether we can get a better outcome. So the two ideas we use here is one is a support vector machine. This just is a method to separate groups of here patients in a high-dimensional data space. Not so, I mean, if you would have two genes, you would have gene 1 here and gene 2 here, and you could put a line in between. And the idea of the support vector machine, because sometimes you can put many lines, that the line which has the biggest or the widest margin is actually the best line. And if you have more than two genes, you instead of putting a line through it, you would with 3 dimension put a surface through it, or with many dimensions hyperplane. And so that's in principle the principle. It's a well-known approach, very successful. The other well-known approach, very successful, which we include here, is the PageRank algorithm, which was developed in 1998 by Sergey Brin and Larry Page, and is a kind of background behind the Google search. And we usually have the feeling that gives us good results. So if you search for one web page, the question is how you want to score this. So here you kind of build this kind of equation, and you solve this, and you get the eigenvector, and this would get the PageRank algorithm. So the theory is the page with the highest PageRank would be the most interesting one. And then we translated this to genes and used this here, and we tested this on a number of different data sets here, all different kinds of data sets from breast cancer. We used actually 2 different endpoints here. The one is the ERB status, so we called it EGFR before, but there's actually a whole family of receptors called the ERB receptors. And EGFR is sometimes known also as ERB1 in this family. because we know the pathway. We wanted to see, do we get now predominantly genes from the pathway? Actually, this endpoint is very easy to predict. We could just look at the HER3 receptors itself. But we actually took them out here. We look at metastasis, which is a relevant endpoint for us. We want to know, do the patients which, after the removal of the cancer, do they stay healthy? And usually if they get sick, usually they can get either a relapse or local recurrence, or often they get a metastasis, which usually then also leads to death. Which is a relevant endpoint, but actually the prediction performance is much less. And actually, just to summarize very shortly, we see in this, including the network knowledge, actually three different things. The one is that the new approach produces more reproducible gene signatures. Actually, one big problem with all these studies, I mean, they never lead to the same gene, which is also understandable because, you have different data and probably a lot of very different classifiers, so you wouldn't expect to get the same gene signatures. But of course, now we bias the classifiers toward genes that we think already have an importance, so of course we will get more often the same gene signatures. This is just the overlap with these 4 data sets with our approach, and you see with our approach it's not very big, and if you just learn gene signatures without knowing the biology, you pretty much don't get any overlap at all. But which is, from the practical, it might not be a theoretical advantage because, I mean, it's obvious that it should be the case, but it's a highly practical advantage because you want to know at some point which genes you consider as important. Okay, in this case, we also say the genes are more meaningful biologically than the genes which you just train by a classifier without including pathway information, meaning for our pathway where we predicted the B status, we usually get genes which are in the gene ontology of being B related as well. So we predict genes which are more meaningful. And the third is, in this case here, on all those data sets and in the combined data set, we did actually also have a better prediction accuracy. So this leads me just to the kind of vision. So in principle, we have all kinds of data for patients or for cells. We have clinical data, okay, patient survives, doesn't survive, is a male or female, age, and so on. At current clinical practice, I think the biomarkers are often histology, so the pathologist looks at it and says, oh, here this is ERB too high. Not? We have now gene expression profiles, either mRNA or microRNA by microarrays or by sequencing. We have SNPs, genome aberration, methylation, and we have especially now knowledge from external databases, maybe about the pathways, about protein-protein interaction, about transcription factor binding sites. So how can we include these and build classification models which allow us to predict outcome for the patient using this kind of cellular networks. Okay, and that was, I think, my